slowly. Okay, this is we continue our job. The next case, like you saw in program, it is a correction of the flexion contracture of the knee. It will be maybe post-traumatic deformity or congenital deformity or some kind of big scars on posterior part of the femur and the tibia. And we program to do the correction of the deformity by closed way. We don't do any adjustive procedures. If it is congenital, it may be done Z-plasty posteriorly, but if it is only post-traumatic contracture, we may do it only by closed way. We apply the frame, we put the hinges, we put the motor, and we correct deformity of the knee joint. Okay. Now we have 90 minutes. Perfect. And we should finish after 25 minutes. Okay. What we do here, we don't have a long bone now because we use many of them. And now we build the frame a little bit compact. How we build the frame? I think for the part of the femur, we use one complete ring because it should be stale with the part of the distal femur. And the proximal part of the femur, we put this 5 of 8 for attaching the proximal part of the femur. What we do now, we start with the wire because this frame is possible to do in a way that I like more than other ways. I don't like to prepare the pre-built frame, and I like to build it step by step, one by one, piece by piece. Okay, what we do, we start with the first wire. We don't put too low this wire because we need to have space to build the hinges. I put like this, plus minus. What I do, I put this wire, I try to put parallel to the joint line. In this way it will be easy for me to build the hinges. I put it parallel to the joint line. Okay, sorry, 1 second. You may do it in fluoroscopy if you are not sure. Okay. You remember that the previous cases, sometimes we put the wire perpendicular to the bone. Here, I try to put it perpendicular or parallel to the joint line, like this. Okay. This here we put it more posterior. Our bolt of connected bolt is in anterior position, and the rings we put it posteriorly because we don't have too much space there with the contracture. The ring, not okay, not good. Change it. Keep like this, please. Okay. Another one. Okay, now we fix it. Okay, keep this ring, please. Okay. Bend the wire. we put an attention. I don't do any comment here because I think you understand how it is done. I do the tension of this wire. Yes, tight it good. Perfect. What I do now, we connect this now with the 5 of 8, and like I said you before, that maybe we change here because I don't have a space to put it. What I do, we return it back of our trick. We attach the frame, meanwhile to attach the bond, because we don't have space to work if you attach the bond here. It's a short segment. We do like this. I put it here. Okay. Put here like this. Okay, we put it anterior, posterior view perfectly. Okay. Okay, now we do this application of this half FIFA phase. Like you understand, it is always a little bit bigger muscles here. And what we do, we build the frame, and this 5 of 8, we should construct a little bit lateral. Put the first rod here. And here I change, I put it anteriorly. Okay. Like this. Okay. What we do now, we put another one here. Another rod. I put it just a little bit external, and I use this connection. Okay. Not exactly parallel. It's not so important now in this case. So they parallel, but they not overlapping the holes of them. That's only for comfortability of the patient we do, like this. Okay, third roll maybe put here, for example. It's only for show you the different opportunities how we may build the frame, like this. Here we connect it differently. We put one plate, not so long plate, yes, 3-hole plate, like this, and bolt and nut. Okay, this is block on the femur we create. Now we start with fixation of this Ring I put here. Okay. I will see. Yes, I put it here. Small bolt. Thank you very much. We have enough space. So obviously, we put it not anteriorly, not posteriorly, just a little bit posterior, but without putting too posterior to prevent too much destruction of the soft tissue. Okay, and do like this. And the bone should be perpendicular of my bit, just a little bit like this. There you go. Okay. Short bolt. Okay, and then line it. And this half pin is not perpendicular to the bone. If you look it from AP view, because like I explained you before, with the first wire we put parallel to the joint line, not parallel to the. Okay, not perpendicular to the anatomical axis, okay? There is a 7 degrees of difference, okay? Just a little bit stable. After that, we put the half pin again on the proximal femur. No one. Okay. Okay. We fixed here. That is your choice. You may do it with half pin if you prefer. Maybe the children or the people have a scars or not so good bone. You may use a wire. You may put 2 crosset wire or use olive wire because they are more stable. But this is more easiest way now for us to put half pin. Now in this system, we just have a really stable frame enough on the femur because we don't do any correction, any adjustment of the femur. It's only stable frame. It's like a base for attaching the hinges and to the correction of the knee. What we do here now, we start to build the hinges, because more important things in this frame is the hinges for correction of the knee. Where we find the hinges? The classic way to look at for this, it is we design the line of the posterior cortex of the femur here. We design the line of the posterior condyle, line of the condyle, posterior border. And this, in the crossing of this area, we find the hinge. You may control it in fluoroscopy, you may do imagination, but now later I show you how the tricks we use to understand if this joint, if this hinges is functional really good or not. What we do now, now we'll try to put the hinges exactly where we design it. I should look it for this. I find it is here. Okay, I put 2-hole post here. Important thing, don't put it too posterior, because if you put it too posterior, it may create the compression of the joint. It is better maybe to do just a little bit anterior, oppositely, in the way when we do distraction, the joint will be open, because if you do it too posterior, during correction, it may create the compression of the joint. If you put it a little bit anterior, it's better. Okay, this is one. We put another one here. Like I said, it's just a little bit anterior. They should look in one to another. If you put the good position the ring, theoretically, you may calculate the holes of the ring and the corresponding. But much more important is realignment of these two rods. Okay, we put them. And now we build the system for the tibia. How we do this? We prepare long rod like this. Now we displace it a little bit more. Okay. Put the frame like this. We don't have, okay, I do like this. I fix the proximal ring and we work more comfortable with the distal one. If you are not comfortable, I change the position of this stuff. Okay, easy to see. Okay, what we do now, we prepare the rods. The length of the rod in this case, you may choose how you want, but it should be long enough and you may prevent to do a little bit of distraction. Maybe I put here 120 to be sure that everything is okay. 120 we use everywhere, every time. And now we have them here. Yes. We remove them and we use them. We may prepare this motor too, maybe it will be helpful. Okay. Okay. Two rods, 120. We use these two rods. Use here maybe one whole rod, but one whole post, but quite better to use two whole female post because they have a much more possibility of movement when we do the hinge. Like this. One. And another one, two hole. Two hole post, yeah, just here. I find it. Okay, now we build this system. Well, my advice here to use a little bit long bolt, because if you use a little bit long bolt to 20 millimeters or 30 millimeters maximum, it is possible to put two nuts together at the end, because this hinge should be always mobile, but not so mobile that you will lose. When you put two nuts, what we may do, you achieve the good stability, and there is no risk that the patient loses this connection. You see, with two nuts, it is not possible to disattach it, but it moves freely, with good freedom. Okay, one. And another, we put it inside, or in the internal position, because the rod, the rings that we want to put distally, it is a ring different size, and the tibia we put the ring, in this case 160, and the femur we put the ring 180. Tie this. We tie this two knot. Okay, two moves good. Now the parallel, perfectly. Okay, this one I should bend before I have a trauma. Okay, now we start connect the distal ring. 160, like I said you. Here it's not exactly the same position, like you see. Now there is a really bad contracture. We adapt the position of these rods to the position of the tibia, like you see here. One more. One knot. Okay, it will be quite in the middle. Okay, one. And another one, like you see, it's not, you can put it inside of the rod. What we do, we put a small plate. Again, this plate. Not. And we adjust it in the way that it's comfortable. And this is touching the tibia here. Okay. Now we do tight a little more. Probably need short a little bit here. Okay. Now just stable. This ring moves, and it should move with our ring. What we do now? We fix the tibia. We may use long post, long cube here, because I start here with putting the half pin. In any case, this is much more comfortable for me, and it is good enough for the patient, because in any case, this half pin don't penetrate too much soft tissue, and we fix really good the tibia now. Obviously, it depends on the contracture of the knee. If there is a good big tension of the posterior part and the fibula, it will be better and quite necessary to fix in the fibula. Now we don't have the fibula if we don't do this. But the fibula should be fixed in the distal part or in the middle for correction. Okay, I do tibia. Okay. Bolt. I respect the anatomy of the tibia. I put this ring perpendicular to the anatomical axis of the tibia. And this way it is easy to calculate everything. We put this. I tighten it. I tighten here. Okay. We may put another half pin here. Small bolt. I put here. Another half pin at the proximal tibia. And I put them in the second and fourth hole of the cube. They are parallel, but they work good together. Good bone. Good quality of bone. Difficult to induce. Okay, stay firmly. Oh, no. Right angle we have? No.
The pipe?
Yes. Ah, yes. Right angle, they call it. Because Americans said that the pipe, it is the pipe of the toilet.
Or toilet, yes.
Yes, this is a pipe, and this is right angle. Yeah. Okay. And now we fix the tibia. If we want, we'd better maybe to put another wire to be complete. Put another wire without olive. Put this. This wire should go parallel to the ring, exactly with the level of the ring. Fix it here. We tied the tip before fix the wire. Okay. Tied the wire, we tighten the tensioner, but now I show you again how we do it in the Russian way. We tie this. Yes, assistant keep the ring from other side, and I do this rotation. Oops. I rotate the wire and the bolt, and we achieve good tension of the wire. Okay, perfect. That's stable enough, like our system. What we do now, we may check how our frame functioned. Remove this wire. This was temporary wire. Fix the knee. Okay. This emotional moment, because we should see how this hinge functions. Like see now it moves good enough. It just a little bit maybe in compression, but it's not normal form of the knee joint in this anatomical example. It's not so perfect. I do just a little bit of distraction here. And this way we do, in any case, we always do distraction of the joint. If it's rigid, we should distract a little bit the capsule or ligaments. What you see, now I control, and the joint moves good enough. But in any case, like you see, I am not so satisfied because it's in anterior position, it go a little bit in conflict, a little bit anterior. What I do, I control more, and maybe I change the position of the rod again, of the hinge, because like I said, you better to have a little bit distraction, better distraction than the compression. Another trick before to change this, what I do, I look at the patient and at his joint, I release this rod like this, okay? I release them and I control what's happened with this rod. I release here, proximal and distal. I try to move the knee like this on the patient. It is I do for the contracture, or maybe when I do the hinges for the children who should to do treatment of the hemimelia and they need to maintain the movement of the knee. The good position of the joint when you do like this and the length of the rod don't change. If you see that the rod is lengthening, it means that it will be compression. If the rod's shortening, it means it will be distraction of the rod. For this reason, what I do, I try to change. I do it just a little bit more anterior. And this way we prevent the compression of the knee joint. Change here. Just like this, I see clinically, and for me it looks that it is a little bit better to tear it up a little bit, the lateral one. I remove this. Okay. I want to change it. And I think will be not enough here. I will do this job. I will put, I need to have female or no. No, I think yes, maybe, but I do in this way. I put here one female, but it will be better to have a female. Or yes, another one trick, maybe I show you it is better again. If you want to change the level of the joint, it was here. What I do, for changing the level of this, I put one male, for example like this. Two holes, where is my two holes? It was here. No, it was there inside. It was inside here. And without disattaching this, what I do, because I want to keep it high a little bit, I leave this like before. But what I do, I put this male here on the rod. I position the male here. And practically, if you don't have other holes free, I use it for the wire or something, but I want to change the position, I put here, and I put the bolt, long one, maybe, like before.
Okay.
Yeah. This bolt comfortable, and we put again 2 nuts. Okay. It's only for doing exercise because you understand it better how it functions. Okay, now we'll do this. The problem is that we change position here, but we don't change here. We reposition it our joint here. I know we need to put the, there is not so good movement here. We need to put washer, small washer. And this way we have more possibility of movement. Okay. We'll see. I save my rod, but it's just now a little bit short. One second. Okay. Mm-hmm. 150 is better. We position this. This is all important manipulation and control you should do, because if you do the frame that is not physiologically adapted to the knee, you may do correction. The frame is so powerful, but you may create dislocation or compression of the knee joint. And this is really dangerous for the patient. Okay, this is not adapted. I don't see here. We should do all this, follow all this detail to achieve a good realignment here. This and this. Keep this, please, because I need to change position here. Like this. Okay, small, need small, yes, rondella. Okay. Okay. abduct here. Okay. You see, I change the position of the hinge. What we do now, like you see here, this is no more compression of the joint. Now the joint have amount of movement, big amount of movement, bigger than before, okay? No more compression. This is our small tricks that we use it to prevent the compression. And now, like I said before, now if I release the nut, distal nut, and proximal nut here, and I do movement of this ring, you see, there is no shortening, there is no lengthening of the nut, and the knee joint moves freely, okay? Okay, now we fixed everything. In this stiff joint like here, it's not easy to understand immediately for this reason. Just like I said before, better to put the hinge just a little bit more anterior and to prevent the compression in this area. But in any case, there is joint moves, and you have these small tricks, and you control the axis of rotation of your joint. Now, we put this system. Now we have a possibility to do correction of the knee. Because you know really good that the knee joint, it is not a simple joint. It is not like a elbow. There is no unique axis of rotation. For this reason, when you do contracture treatment of the knee joint, or you should use some kind of complicated system like a hexapod system, or use this system, but it's much more simple. But in any case, you achieve the same result because there is a ligament that keeps the knee. There is a old soft tissue capsula that maintains the position of the knee. And now we should decide what kind of motor to use, because there is two possibilities here to do the correction. One, it is like we used before, when we use a motor automatical. You remember this motor here. And this motor, we may position it posteriorly. If contracture is not so big, you may put it here like this. If you want, we position it, but you know how this functions like this. We put this motor, and we do lengthening, and we correct the deformity. But I want to show you another different way. I think it's much more powerful and useful for knee contracture, because it is like a elevator, like a гру, come si dice in English?
Crane.
Huh?
Crane.
Crane, crane, exactly. Crane like in Russian. And this is a crane that we may use for correction of the knee deformity. We use this long plate. We attach it to the tibia or to the distal ring of the femur, and we create like a crane system that may permits us to do the correction. I put this. Now we use a rod. We use one rod with the female, like this. It depends of the contraction, depends of how many distractions you do. Better I use again longer one. I use female 3 hole because there is much more freedom here. Okay, after that, I want to attach it to the distal ring, but the better to put the male long one, because more distally your attachment of your rod, better biomechanical effect of this traction. You see, I put like this. I put this here or here, for example. I put the bolt. Okay, not here. And what we put here, we may use or female one hole or with the cube like we used before. I show you maybe with the cube in one hole cube, or in this case I use 2 hole cubes. Okay, it will function the same. I attach it here. Oops. On this plate. And I attach here. Okay, this way we create this crane, like we said before. Then we may do the progressive correction. This plate is strong enough. Obviously, if this the powerful contracture, really rigid knee and everything like this, you may do maybe another adjustment. For example, like this, you may put another male here, another male here, 2 hole, 3 hole when it will be adaptable here. Then this system became more powerful because this prevents the bending of this plate. It became stronger. Like this. Okay, and this way your plate is much more stronger than before, because if in the first time it was keeping only one rod, but in this way you create the double attachment. It's more impossible that this plate bended. And what you do, your patient, what simple manipulation, you release this rod, release this nut, and slowly, you do distraction. Here is my right angle. Slowly we do distraction. And this system, it's put it just a little bit distorted. Okay, now better. All this system should have a freedom for movement, like this. Okay, we do correction, slowly. Now we don't have a good freedom. Okay, we do like this, slowly. moves. Okay, this way, slowly you go up, and up, and up, and up. It's important that this hinge, it will be more distally, and this way it is, the movement like this is more powerful. If you don't like the cube, you may change it. Because 2 holes cube may be a little bit inclined. We may put here, for example, 2 or 3 female or 1 female post like this. Small washer. Okay. Now I see you like much more this system because you see it is much more freedom because the cube was a little bit damaged. And now what you see how we do? We do this distraction progressively, go up, go up, go up. In some way when you arrive to touch this ring, what you may do? You may change the position of this because the important thing when you do this correction, that this distraction direction of this rod should be tangential of the hinges. This is an advantage of this system, that it became more powerful. When you arrive at this point, you may change the position of these hinges, distal, for example, here, which you put here, and it's biological or mechanical is much more powerful. In some way, when you arrive to contact here, what you do, or you should keep this plate a little bit higher, or you may put the posterior system in the motor, posterior motor, or simple rod that you put here, distraction rod with the hinges, you may finish the correction manipulation. If you want, I show you, maybe put like this. I remove it from here. We may put here a little bit high position of this plate, or you may do it just in the beginning. Okay. And do it like this. Okay, and this system functions the same. This way, when you are arriving at this position, now you may use less longer bolt like this, because it will be too long anteriorly. Some way patient give you advice, doctor, may you change me this rod, it's too long. And say, okay, I satisfied you, and I put the shorter long rod like this. We connect it between them to create another hinge here. And like you see, now we arrive to complete correction. Complete correction. just a little bit longer. And the washer we put here. Oop, big one, better big one. Like this. Okay, and here, female again. Small bolt. The nut. Okay, in this way, like you see, the last step of the treatment, we do like this. We do correction, correction, correction like this. And we arrived to the parallel ring. If you see that it's not so comfortable, and do it again, change here. And we arrive to parallel position. Okay. This is one of the way to do the correction of the knee joint. And like I said, you may use one or another. This, I think, it's much more powerful. It's stronger. Another one, it's possible to do the same, but when the contracture is not so big, we put the motor posteriorly like this, and we do correction. This is a little bit uncomfortable for the patient for the bed because he should stay supine position, but the patient rotated. And if you put it anteriorly, just a little bit comfortable for the patient. Okay? I'm finished this job. If you have any question, ask me please, and I explain you maybe what you want to hear from me. Now, like you see here, there is a little bit of anterior displacement of the knee. I think it obviously this anatomical model, it's not perfect. But why I explain you why it is happened, this displacement, because the hinges, it was a little bit too high, because if we put the hinges longer, for example, I change here, I don't put 4 holes, but if I put here the longer rod, like this, I put maybe 4 holes, 4 holes post. It is like a hinges for correction of the deformity. When we put this, the hinge, it will be more distally. And the same here. We change the position. And we put the long one. Okay, I do this compression. Obviously, it should be done in the beginning. Okay, like this. But only for understand, because more distal it hinges, less displacement you achieve during correction. Now it's just to displace it more. We do like this. Change this. Give him more freedom, like this. Okay, I'll realign it better. Oops. Okay, many tricks here, and what now I show you how this hinge should function, because it's more distal hinge, and what we do when we do correction, this incline, you see there is no more displacement of the joint. This hinge is more anatomical, and like you see now, there is no more movement because the first hinge was too high, and it was created the displacement anterior. This way, there is no displacement because it was better to calculate this kind of adjustment of the joint. Okay? Now finished finally. If you have any question, because we have another workshop. If